can always give them my number. I'm happy to talk to them. But it's a timing issue. So.
Speaking of timing, that's when we usually have these conversations. Is like you're in the OR, we're waiting, we need. I'm not giving them all 4 bags, and I want to get 2. And I'm always at a loss. Like I can only tell you what you're supposed to do. I can't.
Yeah, the biggest problem right now that the AABB is concerned about is underdosing of plasma, because a lot of the docs were trained for 2, and it's stuck in their head, and they ordered 2 of everything. But 2, you're right, 2 doesn't reverse a patient who has an INR of 3.8. It's not enough for an adult. You really want to look at that deficit. You could always tell them, hey, repeat another INR. Make sure that you reversed your deficit. It's going to tell you right there if you're reversed or not. And the danger really is that there's an incomplete reversal. They gave their 2 bags and they think they're done because they didn't think about the dose. They didn't think about the amount of deficit, and they didn't give a proper.
And they continue to bleed.
And they continue to bleed. Yeah, and then they sign out. All right, which one? Plavix. The dreaded Plavix.
What is the bump you should expect from 1 unit of blood cells in the hemoglobin?
It's going for the platelet.
Once again, platelets.
It's an anti-platelet.
So,
Nasty.
couldn't you just give another unit of platelets?
Yeah. So here's the thing with platelet inhibitors. The metabolites also inhibit the platelet. So if they just took their Plavix this morning, and now you need to reverse them because you got to do some surgery or something, and you give a platelet, the metabolite from the Plavix that they took is still being processed and comes over and inhibits your new platelets. So you might have to give 2 if they just took their Plavix like today or yesterday. You're probably going to have to do 2 because the metabolite is so active and gets the new platelets. If it's been like 3 or 4 or 5 days, probably 1 platelet. Great. 10A. Woo-hoo. 10A inhibitors.
How's it going?
Okay, take a test. The number on there says how many tickets you get. If you get the
Yeah, you need calcium. Yep. Coagulation needs calcium. Blood has citrate. So when you have a bleeding patient and you're transfusing them, you are using a lot of calcium. Clotting takes calcium, and blood transfusions take calcium, and patients can become hypocalcemic. Every year, at least one resident calls me telling me the patient's having a seizure, and it's tetany, because we made the patient hypocalcemic. They're using their calcium. The blood's citrated, you're pushing the Krebs cycle, you're using more calcium, and the patient becomes hypocalcemic and goes and the treatment is calcium. So here's a 10A, and if you look at the names of the drugs, they have 10A in the name of the drug. See the 10A?
Well, overload.
It's banning the 10A, get it?
We use
10A ban, get it? Get
So, because remember,
and then Xarelto, there's the 10A
FFP
again.
is given at 10 mLs per kilo.
So if you're trying to remember, like, so if you see the drug and you're like, oh, what does that inhibit again? And then if you see, like, look for the 10A in the name, and then you know that that's 10A inhibitor. So there is an antidote on the market now for 10A that the FDA approved. It has Coil, has 10A, is in the name of
The physicians order it by ml.
because we have to be really cute about there it is. All right,
That's what you meant by it's in the name. I'm like,
see that 10A in the name of Andexa to reverse the 10A inhibitor. But this drug costs like 30 grand a dose.
Because it's brand new, it's made.
And you can't even get it because they don't make a lot of it, so it's really hard to get. Pharmacy doesn't have it. So what you're going to do instead is you're going to aim right here at the prothrombin complex. You want to give them some prothrombin complex because they can't build their own because you're blocking their 10A, so you're going to give them some, yeah, exactly. PCC. to get around this. You can't give them platelets or plasma because it's not strong enough. And you're not inhibiting a platelet, so that won't help. Anyway.
Let me just tell you, she's 24.
There's only one left. Ramen inhibitors,
I think she was like closer to 20.
Pradaxa.
None of that thought. Okay. But,
Right here it is.
see,
2A. And 2A is really powerful. Thrombins. It takes your fibrinogen, makes it into fibrin. It comes back over here and it activates your factor VIII. And it comes over here and it activates your platelet.
Which helps form your soft plug.
Right. So
yes, no, I don't know.
thrombin, really potent stuff. It's just like it's all over the cascade. It pushes the whole cascade and it activates your platelets. So thrombin makes a clot. Oh my gosh.
It also activates, what is it, von Willebrand factor?
And then there's
Yeah,
febrile,
yep. It's up
non-hemolytic,
here. Yep.
transfusion infection.
So really powerful.
And others.
There is an antidote on the market
We're gonna have tickets.
for the Pradaxa. Right now, it's an antibody that binds to the drug to stop it from attacking the thrombin. Perhaps bind. Pradaxa bind. So, and of course, we can't afford it because that's like 30 grand.
20,000.
Yeah, exactly. And the pharmacy won't even carry it. Even if they wanted to carry it, you probably can't get any because it's only going to go to like major centers. So again, you're going to use prothrombin complex to get past that if you have to. FIBA. It's prothrombin complex concentrate. There's some different ones. FIBA is actually stronger than the K-Centra in this case, but again, you're going to use what you have. I mean, if the patient's hemorrhaging, you're going to go for the K-Centra. But you're not going to order a bag of platelets. You're not going to order plasma because that's not going to do it in this case.
Because your von Willebrand factor is not activated, your factor 2 is not activated, your 2A is not activated, so
Yeah.
you're just kind of flushing it.
You got to go for something bigger. But, yeah.
And then you said about the DDAVP
Yeah.
and the cryo
What are these
for your uremic patients.
Right, exactly. Because you want to activate these platelets. So if you have uremia, it's the plasma that's the problem. Your platelets are not, they're like, your platelets are inhibited. If you give them more platelets, you just have more inhibited platelets in the crappy plasma. So you really have to activate those platelets, and the way to do it, you got to get the fibrinogen, von Willebrand factor. I ran out of room, but I could have put factor 8 here. You want all these things to come together, activate your platelet in the uremic plasma. And the way to do that, DDAVP, it activates your endothelium, and your endothelium spits out. Like it's got these granules in it, and the granules and endothelial cells along the blood vessels, full of factor 8, full of fibrinogen, full of von Willebrand factor. So you give them the DDAVP, and they spit it all out in plasma, and then it activates your platelet. If you can't give the patient DDAVP, just order cryo, because cryo is the same thing. It's von Willebrand factor, factor 8, fibrinogen, so it has the same thing. It activates platelets. So cryo is good. You can replace your, if you have a patient who's really low on fibrinogen, you can replace their fibrinogen. If you have a hemophiliac or von Willebrand factor, somebody comes in and you're like, oh my gosh, I can't get any factor 8, I don't have any factor, and the patient didn't bring any, and the pharmacy doesn't have any. Cryo is what you use in emergency because it's von Willebrand factor and factor 8. But that's the other thing it's really good for. When you give them cryo, you activate your platelets too. So it's a potent platelet.
Okay, all right. Well,
It's great stuff.